Good afternoon, everyone. It is a great pleasure for us to take part in this GuardHeart webinar under the coordination of Professor Alida Caforio. Is just trying to get to our room. And today's session will focus on the relationship between the carpal tunnel syndrome and cardiac amyloidosis. We chose this topic because of the growing clinical and research interest in this theme, including in our institution. And first, Pedro Palma and Helena Moreira will now give two brief presentations on the subject. Please, Pedro.
Okay, I'll just try to share my presentation. Okay.
Yes, this is great. Thank you.
Okay, thank you very much. Hi, everyone, and welcome. My name is Pedro, and I'm a cardiology resident at São João University Hospital here in Porto, Portugal. As Professor Elizabeth said, today's session is about predicting ATTR amyloidosis at the time of carpal tunnel syndrome. Over the next few minutes, I'll give a brief overview of the subject. After that, my colleague Helena will present a few clinical cases and our research in this area. And finally, Professor Elizabeth will conclude with some clinical recommendations. So before we move on, I would like to get a sense of your current practice in your centers. So could you please answer in the chat whether you screen for ATTR cardiomyopathy in patients with carpal tunnel syndrome? Please answer A if you do this routinely, B if you only screen selected or high-risk patients, or C if screening is not performed. Okay. We have three answers, and all of them are B, only in selected or high-risk cases. So, to frame our discussion, and as you all know, ATTR cardiomyopathy is an increasingly recognized, yet still frequently underdiagnosed cause of heart failure. Importantly, carpal tunnel syndrome is one of its best recognized early manifestations, often appearing years before cardiac symptoms. For this reason, carpal tunnel release has been proposed as a unique opportunity for early diagnosis and intervention, as it allows for tissue biopsy to demonstrate amyloid deposition. So why does CTS often appear years before cardiac manifestations in ATTR amyloidosis? Amyloid tends to accumulate in tendons and ligaments early, even when the overall amyloid burden is still quite low. One hypothesis is that the tissues are being relatively avascular, exposed to constant mechanical stress and rich extracellular matrix, provide a favorable environment for early amyloid deposition. This helps to explain the characteristic pattern of musculoskeletal involvement seen in ATTR, including, as you can see, biceps tendon rupture, CTS, trigger finger, lumbar spinal stenosis. In contrast, the heart usually requires a much greater degree of myocardial infiltration before structural changes or symptoms become clinically apparent. This cluster of extracardiac findings forms the basis of the emerging cardio-orthopedic disease concept, highlighting how these musculoskeletal manifestations can serve as important red flags and crucial opportunity for early detection of ATTR cardiomyopathy. Large-scale epidemiological data also support this link between CTS and cardiac disease. In this Danish nationwide registry study with around 56,000 patients who underwent carpal tunnel surgery were compared with age and sex match controls from the general population. As you can see, CTS, or carpal tunnel surgery, was associated with a future diagnosis of amyloidosis with a hazard ratio of around 12. And in patients with bilateral CTS surgery, this hazard ratio increased to roughly 30. CTS was also associated with a higher incidence of heart failure with an adjusted hazard ratio of about 1.5, as well as increased rates of atrial fibrillation, conduction disease, and pacemaker implantation. Similar findings have been observed in the All of Us research program, a large contemporary multi-ethnic US cohort. This analysis included approximately 167,000 adults without heart failure or amyloidosis, with a median age of 54 years. CTS was diagnosed in about 7% of the participants and was independently associated with a higher risk of incident heart failure with an adjusted hazard ratio of 1.13 as an almost threefold higher risk of incident amyloidosis. Thus, even in this relatively young and diverse population, CTS appears to identify individuals at an increased long-term risk for both heart failure and amyloid disease. On the other side, among patients with established ATTR, the prevalence of carpal tunnel syndrome is remarkably high. In wild-type ATTR, CTS is very common, affecting approximately 50% of referred patients, and symptoms typically precede the cardiac diagnosis by 5 to 10 years and often are the initial clinical manifestation. In this Canadian neurology cohort of patients with wild-type ATTR, 94% of patients had nerve conduction studies demonstrating median nerve neuropathy, 53% had bilateral involvement, and among patients with pre-existing CTS, 76% have had bilateral disease and 62 had undergone surgery. CTS also appeared more severe, rapidly progressive, and more frequently recurrent than CTS in the general population. I will now briefly discuss the biopsy technique during carpal tunnel release. At present, there's no universally accepted standard regarding which tissue is best to sample. Amyloid can be detected either in the transverse carpal ligament or in the tenosynovium, and both can be collected during the surgery with minimal additional risk or time. Several studies have shown similar positivity rates between the two tissues, and a more recent one showed a 93% concordance between two. One point to highlight is that another study reported a lower prevalence of positivity when the biopsies were taken during endoscopic carpal tunnel release compared to open procedures. So this raises the possibility that the surgical technique may influence the biopsy yield, and for these reasons, some authors recommend to do an extended open approach in patients where amyloidosis is suspected, both to ensure optimal decompression and to allow for adequate sampling. Once the tissue is obtained, the standard first step is Congo red staining, followed by examination under polarized light to look for the characteristic apple green birefringence, which confirms the amyloid deposition. After that, the crucial next step is subtyping, and this can be done with immunohistochemistry, mass spectrometry, and immunoelectron microscopy. And this depends on the local expertise and availability. So several studies have looked at biopsy results in the general population with CTS, meaning patients undergoing carpal tunnel release without any specific pre-selection criteria. When we combine this data, the overall prevalence of a positive biopsy is around 18%. However, there is quite a bit of geographic variation. If we stratify by region, Japanese cohorts show positivity rates around 30%, whereas non-Japanese cohorts are closer to around 11%. This difference is thought to reflect the higher described prevalence of amyloidosis in Japan compared to Europe and North America, but also differences in study designs, patient selection can also contribute. In this table, I summarized the available evidence and the key characteristics of the published studies. On this table now, I'm showing the data from studies that selected higher risk CTS patients for biopsy rather than unselected patients. Among these screened patients, the highest biopsy positivity was by Di Benedetto et al. In 2022, which reported around 29% by including men over 50 and women over 60 in the biopsy cohort. Interestingly, Sperry et al. Also used the same criteria, but observed a lower positivity rate, about 10% among the selected patients. So this highlights that the biopsy yield can vary substantially even when similar selection criteria are applied, likely reflecting differences in the population, referral patterns, and center experiences. It's also worth noting that in one surgical series of patients with confirmed amyloidosis, the biopsy yield was 100% for both tenosynovium and transverse carpal ligament samples, underscoring that these tissues reliably contain amyloid once systemic disease is present. Only 4 of all the studies I presented evaluated asymptomatic patients with a positive biopsy for underlying cardiac involvement. In all of these studies, as you can see, patients underwent ECG, echo, and biomarker assessment, and the definitive diagnosis was established with a bone scintigraphy scan. Across these cohorts, around 5 to 20% of the biopsy-positive patients who completed the cardiac screening were found to have cardiac amyloidosis, and all 12 confirmed cases were ATTR wild type. When viewed in relation to the entire study populations, this translates to 1% of unselected CTS patients and 2% of the higher risk CTS patients. A key limitation, however, is that these biopsy-positive patients have not been followed up longitudinally in any of these studies, so the true incidence of cardiac amyloidosis developing over time is likely higher than currently reported. So on this slide, I want to briefly address what we know and what we yet don't know about the risk factors for a positive biopsy. Most available data come from small studies using heterogeneous criteria, so it's still difficult to clearly define which patients should be systematically biopsied. This nomogram on the right, proposed by Sud et al., it's helpful, but it predicts incident amyloidosis after carpal tunnel release, not biopsy positivity, and it hasn't been prospectively validated. Across all the published series, 2 factors consistently emerge as associated with a positive biopsy: older age and male sex, and another potential risk factors have been suggested, but the evidence is not yet robust. So the key point is that while we have some signals, there's still a clear need for multi-center prospective studies to build and validate a reliable prediction model for biopsy-positive ATTR in CTS patients. To finish, another important piece of evidence comes from the CACTUS study. This study evaluated patients 5 to 15 years after surgery for bilateral CTS. Among the 250 participants, the prevalence of previously unrecognized cardiac amyloidosis was 4.8% overall and around 9% in men, with all cases being wild-type ATTR and mostly in early-stage disease. As you can see on the right, the diagnostic yield increased further to around 21% when focusing on non-obese men with age over 70 years. Interestingly, this prevalence of cardiac ATTR closely mirrors the previously reported prevalence of ATTR deposits in the carpal ligament at the time of the surgery, suggesting that the positive biopsy may herald future development of cardiac ATTR. This hypothesis, however, still requires confirmation in prospective studies. So now I will pass to Elena, which will present a few of our clinical cases and our research in this area.
I'll try to share my slides. Okay, I was just put in presentation mode. I think, yeah, everything is fine, right? So as Pedro already presented, I'm also a cardiology resident from Hospital São João, and here I'm in this presentation. I'll try to present our data from a study that we decided to undergo based on this current evidence. So as we know, we wanted with this study, with the Carpal study, to try to determine the evidence that exists that supports the association between cardiac amyloidosis and carpal tunnel syndrome, and possibly try to determine which patients will benefit from the cardiac amyloidosis screening at the time of the CTS surgery when they are referred to our consultation. So what we did, we included patients that were referred to our orthopedics consultation, and afterwards they would be referred to also to the rheumatology consultation. And these were patients that were older, 60 years or older, with symptomatic idiopathic carpal tunnel syndrome requiring surgery. So we excluded patients that we would know that we would have other plausible causes for CTS. So patients with diabetes, hypothyroidism, advanced CKD under hemodialysis, inflammatory arthropathies, space-occupying lesions, and other potential infectious synovitis and other kinds of causes. These patients were all excluded, so we included only patients that had a high idiopathic CTS. So to diagnose the carpal tunnel syndrome, we included, of course, a clinical history and some kind of tests at our physical examination with a Tinel and Fallon final tests, and also with a sensory evaluation. And all of our patients underwent nerve conduction systems with electromyography, and all of our patients underwent wrist ultrasound to exclude space-occupying lesions, and at the same time to measure the area of the transverse area of the median nerve. All patients were proposed to do an EKG, a cardiac scintigraphy with technetium DPD, and they were also proposed for a tenosynovial biopsy at the time of the carpal tunnel surgery. The additional cardiovascular workup would depend on the initial findings. So the patients would undergo complementary blood and urinary assay and transthoracic echocardiogram, and potentially MRI and genetic testing for ATTR, depending on the initial findings. So we included 22 patients. Most of our patients were female, and they had a mean age of 72 years old. And most of our patients had at least kind of severity, at least some moderate to severe bilateral carpal tunnel syndrome. Two of these patients already had a previous history of ischemic heart disease, but they were all asymptomatic with no major cardiac symptoms. And as we proposed, all of our patients underwent an EKG and a cardiac scintigraphy with technetium DPD at the time of the carpal tunnel surgery, carpal tunnel syndrome surgery. Unfortunately, due to some kind of logistical constraints, not of all patients that were proposed for the tenosynovial biopsy underwent the biopsy, but half of our cohort, 12 patients, underwent the tenosynovial biopsy. And what we found in these 12 patients that underwent biopsy, we found that 3 patients had a histopathological examination positive for red Congo staining, and 2 of these had this confirmation with mass spectrometry that confirmed the presence of ATTR amyloid in these tissues. And of these 2, one of them in the further cardiac workup that was realized, we proceeded to do, had a confirmation of cardiac ATTR amyloidosis. From the all cohorts, so from all the 22 patients that we included, 4 patients had a positive scintigraphy with Perugini scores of 2 or 3, and when they underwent the further workup, including the exclusion, the blood and urinary assays for exclusion for AL amyloidosis, and they all underwent genetic testing, and we had the final conclusion that these patients had evidence of ATTR wild-type cardiac amyloidosis. In all of our patients, they had at least some kind of moderate to severe LV hypertrophy. 2 of them had no abnormalities at baseline EKG, and all of them had some kind of late gadolinium enhancement in each MRI that they underwent, with some kind of heterogeneous distribution patterns. So now we wanted to highlight some of our cases, some cases with positive biopsy, some cases with concomitant positive biopsy, and also cardiac workup. So we'll try to share some of our perspectives and then open the discussion. So we bring firstly our case 13. It's a case where there was a positive biopsy and also a positive cardiac workup. So this was a 86-year-old male with no previous cardiovascular history. He was, as we can classify, under class 1 of the New York Heart Association, and he had some kind of symptoms regarding to the carpal tunnel syndrome from a long time ago, since he was 66 years old. But he was only referred a little bit late to our orthopedics consultation. He underwent a clinical examination. The nerve conduction systems and the wrist ultrasound were also performed, and the exams confirmed the evidence of bilateral carpal tunnel syndrome, and the patient underwent right carpal tunnel syndrome release surgery, as the procedure demanded, the patient also underwent an EKG, which had some kind of abnormalities with sinus bradycardia and evidence of left anterior fascicular block. And he also underwent the cardiac scintigraphy, which had a Perugini score of 3. The blood analysis didn't have major abnormalities with no signs of cardiac lesion, and unfortunately we don't have access now to the transthoracic echo images, but the transthoracic echo showed that the patient already had some kind of LV hypertrophy with a maximum thickness of 12 at the basal intraventricular septum, and he had a preserved systolic ventricular function with a preserved GLS. The patient underwent also cardiac MRI, which confirmed our first suspicions with a not depicable hypertrophy, with an hypertrophy that in the MRI we would measure as a maximum of 14 millimeters at the basal intraventricular septum segment, and the patient had some kind of mild abnormalities regarding to the late gadolinium enhancement. So we can check like in the image in the upper right that the patient had some kind of intramyocardial late gadolinium enhancement in the basal infralateral segments, but something that was quite mild, let's say this way. Now we want to share another case, a case that was negative for biopsy, but in the cardiac workup, in the first cardiac workup with EKG and the cardiac scintigraphy was positive. So this was an 81-year-old male with no previous cardiovascular history and no major cardiac symptoms, with also class 1 of the New York Heart Association. He had symptoms regarding to the carpal tunnel syndrome since he was 80 years old, so it's some kind of symptoms that haven't taken too long, let's say this way. So he was referred quite quickly for our consultation, and he underwent left carpal tunnel release surgery. Baseline, he had an EKG that had already some kind of abnormalities. He was in sinus rhythm, but he already had a first degree AV block, and he had our quite famous pseudoinfarction pattern, as you can see in the anterior leads. Also, he underwent the cardiac scintigraphy, which showed a Perugini score also of 3. The blood analysis has some kind of abnormalities regarding to the myocardial lesion markers with a high sensitivity troponin of 73. Our upper limit for males is around 35, so we can check already here some kind of degree of cardiac lesion. And we also don't have the available images of the transthoracic echo, but the transthoracic echo showed a moderate and concentric LV hypertrophy with a maximum thickness of 40 millimeters. And also the patient already still had a preserved left ventricular ejection fraction. He had already a diminished lobar longitudinal strain of 10%. He also underwent the cardiac MRI, and our cardiac MRI showed a diffuse pattern of late gadolinium enhancement, subendocardial pattern, predominantly in the basal septums, and also he had some kind of intramyocardial late gadolinium enhancement in the mid-apical segments of the interventricular septum. He had high values of T1 native with around 1,500 and an extracellular volume calculated around 39%. Our third case that we want to bring, it's a case with positive biopsy, but with a negative cardiac workup. This was a 60 years old male. He had a previous history of ischemic heart disease. He had a previous STEMI, and he underwent angioplasty of the left anterior descendant artery. He was in class 1 of the New York Heart Association. He had some symptoms regarding to the carpal tunnel syndrome since he was 62 years old. He also underwent all the first examinations to confirm the evidence of bilateral carpal tunnel syndrome, and he was submitted to bilateral surgery. He underwent as protocol an EKG before the surgery, which showed a sinus rhythm, but for R wave progression in the precordial leads, but these were related to the previous MI that the patient already had. And he underwent the cardiac scintigraphy with technetium DPD, and he had a negative scintigraphy with a Perugini score of 0. And the blood and urinary assays didn't show any kind of abnormality. So with our findings, we want to raise some questions, and we will have to think about, should we incorporate the cardiovascular assessment in our routine consultations of patients that are being observed regarding to the carpal tunnel syndrome, especially if it's bilateral? Should we screen for cardiac amyloidosis older patients with symptomatic and bilateral and idiopathic carpal tunnel syndrome that will require surgery? And when we have these patients that will require surgery, and when we have high clinical suspicion, should they go, all of them, undergo tenosynovial biopsy? Some questions that we have asked ourselves, and we'll have to think about. And we need further data to establish this cost effectiveness of various screening strategies. And we will need the promotion of multidisciplinary discussion. We'll have to involve not only cardiologists, but we'll have to involve primary care physicians, orthopedics, rheumatologists, to optimize our screening methods and further management. And particularly, we have to really raise awareness for the association of carpal tunnel syndrome and cardiac amyloidosis, to facilitate the early diagnosis and to possibly improve our outcomes in our patients. And now I will hand over the presentation for Professor Elizabeth. She will finish the presentations.
Thank you, Elena. So before we start the discussion, I will briefly do a summary, if Professor Alida Caforio agree with this. Yeah. So to summarize some of the ideas that have emerged over the past few years, we can say that from a cardiological perspective, it has become clear that there is a high proportion of patients with cardiac ATTR amyloidosis who have a history of carpal tunnel syndrome, often diagnosed several years before the onset of cardiac disease. And this evidence led us to view amyloidosis as a systemic condition in which carpal tunnel syndrome involvement may play an important role in the early diagnosis. Naturally, this shifts our attention toward these patients. And in some individuals undergoing surgery, it is possible to confirm the presence of amyloid deposits, particularly transthyretin, through synovial tissue biopsy. However, the reported percentage vary widely across studies depending on the characteristics of the selected populations. On the other hand, and regardless of the biopsy results, these patients have also been shown to have a higher risk of development heart failure and cardiac amyloidosis, although the absolute risk remains low. So the diagnosis of cardiac amyloidosis can be made at the time of the surgery, as in our patients, or several years afterwards, although most cases are identified in preclinical stages. So biopsies are not essential, or maybe not essential, to identify these patients, but cardiac screening should instead rely on other variables that have been associated with higher risk in different studies, such as older age, male sex, bilateral symptoms, the need for surgical intervention, or the presence of other clinical manifestations or red flags. Another important question is how to conduct this screening, especially given the potentially large number of individuals involved. Options include ECG, echocardiography with attention to more advanced parameters, and biomarkers such as troponin and natriuretic peptides. As we are often dealing with an older population, age-adjusted BNP threshold may be relevant. And finally, there is a lack of clinical trials demonstrating the benefit of such screening, especially whether early pharmacological interventions can alter the prognosis. And we also lack cost-effectiveness analysis and prospective studies that clearly define the risk of cardiac disease progression or of new onset cardiomyopathy after carpal tunnel diagnosis or surgery. And for this purpose, robust registries would be extremely valuable. So after that, I think we have time for some discussion, and it would be interesting to know if in fact this screening is being carried out in most institutions, and what is the protocol that is being used for that. So,
Elisabeth, thank you for this nice, very nice description, nice cases. I'm sorry, I had a problem with the Zoom link and I connected a little bit later. And now I have double. I can see myself doubled. I don't know why. And
we are having some problems with sound.
The audience.
Alida, do you hear me? because there was an echo, and you are twice in the room now. So maybe it is possible to end one connection and to stay at the other one, because now we hear you twice or not.
I try, but I don't guarantee what happens. So we need.
I will try to delete one connection.
Yeah, please go ahead.
Remove. Hopefully.
I will leave from here, maybe. Done? You've done. Okay, so I have just to start. I mean, of course, it would be nice to know from the audience whether there are any questions. Clearly, it's a very interesting tool because it looks that it detects the disease very early, even 10 if more years before. So my question is, how invasive is actually the biopsy? I mean, what are the complications and what are, let's say, the possible side effects of doing a biopsy in these elderly people? They are undergoing surgery anyway. And so, in a way, it would be nice to see the results in all of them who are undergoing surgery for bilateral carpal syndrome, unless, I mean, the procedure is somehow difficult to perform or with a serious possible complications.
Yes, well, I think the procedure has a very low risk of complications. We have no complications in our patients, and in the literature, they say the same. So I think it's more the coordination between the surgeon and then the pathology laboratory. Because I think the biopsy, the procedure is easy to perform and with a low risk of complications. So the question is here is how we can see this procedure to be useful for the patient, for the future of that patient. So the idea, it should be the main for a coordinated work between surgeons and the medical team, usually not cardiology involved at first time. And but our mission here is to involve them and to get them with this cardiac future risk.
So thank you. I mean, this is very nice to know. However, how many, let's say, interventions are done, let's say, in a week in an orthopedic surgery? How many patients and how long does it take to get the biopsy? Does this, of course, it will be longer, the intervention, but that's another point, I think.
Yes, but I think there are a lot of patients weekly. We have I don't know the numbers, but I think every week around six patients they are submitted to carpal surgery, and the procedure is not very prolonged in time, but the surgeons have always very to to end the surgery. But we have a lot of patients, of course, a lot of candidates, and that's the problem because we need to have a strategy to select who who should perform the biopsy. This is a common disease in the general population.
I understand. So are there any questions from the participants? No? You can maybe send also via chat some questions.
We have a question from Egle Irminiana.
Egle, yes.
Yes, you can talk.
Thank you for the topic. Thank you for gathering us together. It's a very nice topic, because we are a little bit also involved in Lithuanian University of Health Sciences. We have the study, inside our university hospital together with plastic surgeons, hand surgeons. And we have now about 130 biopsies, I think, performed, and we found about 10% with ATTR positive and maybe about 3% of cardiac amyloidosis. And we started early these patients. But the other thing that we are checking these patients because the study is coming from 2020. And these, positive for amyloidosis, but for negative for cardiac amyloidosis, we are checking them every 2 years, or maybe every year, but they are still negative. And the question is how to look after these patients that they have no cardiac involvement, but they are still ATTR positive. So I think it is also an unanswered question, and maybe some study more, more countries, more more universities together to know these answers, get these answers for the question. So
Yes.
what do you think about that? How you are checking this that we have negative cardiac involvement without cardiac involvement?
And with a positive biopsy?
Yes, positive
Those
biopsy,
cases,
negative
yes.
cardiac involvement.
Yes, we are trying to see those patients have a follow-up 2 years of interval, but we don't know if it is necessary or not. So I completely agree with you that it should be very useful to have a registry with several hospitals, because we really need that information to corroborate our decisions, our protocols. Otherwise, we could be following these patients for nothing. And I think that information is really important.
Okay, thank you.
Elisabetta, do you mean, to follow, and Egle, would you think of following patients in a registry with a positive biopsy and a negative cardiac involvement, negative
Yes.
for cardiac involvement?
Yes.
That's the idea, because of course, those that are positive, it's done. I mean, there is a, because what I might have missed a couple of slides in the beginning. What does the literature say about the timing? I mean, the association of bilateral syndrome with cardiac involvement. It's very variable, I think.
Yeah,
Is the frequency of cardiac involvement in patients with bilateral syndrome?
Yes, in patients with ATTR, the bilateral is much common, and it's also as we were saying, it's much common, and it's also a risk factor for developing ATTR and for the positive biopsy. So yes, both the bilateral and also the positive biopsy seem to predict the ATTR in the follow-up. I'm not sure there's a study that tells us if it's bilateral, if the time to the development of the cardiac involvement is any different. I don't recall reading anything about that. But yes, it's certainly a risk factor.
I mean, the other possibility, I think, would be to see in the general population of ATTR patients the frequency of bilateral carpal syndrome. I mean, in a large population now, I mean, there are several institutions with several patients with ATTR, and actually the bilateral carpal syndrome is in a way considered a red flag for the disease. So I can imagine that nowadays every cardiologist seeing a patient with bilateral carpal syndrome can think of amyloidosis. So probably this would be the easiest way. But still, if in specific settings there is, let's say, an orthopedic or surgery team that is particularly interested in this, it would be nice also to have the biopsy of all bilateral carpal syndrome to have an idea of the frequency of ATTR and also, I mean, the follow-up. I mean, I think the information is valuable both ways.
Yeah. Yes, we agree. I think so. But what we really need is the follow-up of these cohorts, because we already have an idea of the percentage of positive biopsies, but we don't know really how to manage this in the future, especially when the patient has no cardiac involvement at the first evaluation. So.
And one question.
Any other questions? Please, Egle, go ahead.
Are you starting to treat with a grade 1 in these patients with grade 1 cardiac involvement, specific therapy for these patients with positive ATTR in the carpal tunnel and
No.
grade 1 in the heart, no? This is also,
No.
I think that...
Yes. We don't treat, but we don't have the evidence for that yet.
I think
So
that
it's
because we
also,
are thinking about the more early treatment, not only the diagnosis, then this is important because I think that we are waiting too long for the start of the treatment. Maybe this is because of the costness of the treatment, but this would be the rational option, you know, earlier to start treatment, that we have less complications and less progression of the disease. So
yes, of course.
Thank you.
Yes. Some groups are treating with diflunisal as an alternative to other more expensive treatments.
Yeah.
So, but we really need more evidence about the efficacy of the treatments in the early phase, because we don't know also the rate of progression of the disease. We don't have guarantees that the disease will be stable for a long time or not. So there is part of the history that we really need to know more, I think. So registries, yes, are important.
And also, I thank you for the presentation and very interesting cases. And the case number 17, it was more interesting for me that it was negative for carpal tunnel, how to say, injury, no ATTR in the synovium, but it was grade 3 perugini in the heart. So it's quite rare, you know. I think that with the symptoms of the carpal tunnel, without ATTR in the carpal tunnel, and with severe cardiac involvement. So it's quite rare, I think, and very interesting. So thank you for different patients. Thank you.
Are there any further questions from the audience?
Yes, hello.
Hi, Stellan.
Hi, from Sweden, Stellan Mörner. A question about the fat biopsy. It wasn't mentioned, but do we know anything about the relationship between biopsy of the synovium compared to a fat biopsy, which is much more available? For example, for follow-up studies or continuing following the patient. What do we know about that?
Yeah, that's an interesting point, but really I don't have an idea of that kind of study comparing the both biopsies.
So should we do both? Egle was comparing, talking about the patient with negative biopsy, but still a grade 3 Perugi score. What would the fat biopsy have shown in that patient? We don't know, but maybe that would have been positive.
Or not.
Yes. Yes. Or not.
How in our institution more fat biopsy for AL amyloidosis, but less for ATTR. But still now we have the new case of genetic variant ATTR that we found everywhere in the heart and also in the fat. You know, everywhere this transthyretin protein. But we have also no such a practice, you know, to take. For example, this fat biopsy together with the synovium, the same. But still, it's a very interesting idea, I think, and maybe we have to check these patients also, because such a new topic and.
Yeah. Do you perform fat biopsies in your institutions at all?
Yes, we perform.
Yeah.
Yes, we perform, but more when we suspect AL amyloidosis, you know, and we find.
Not for
For ATTR, no.
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 Okay. We do lots of fat biopsies.
And what is the % of that in your?
I really don't know, because I work with hypertrophic cardiomyopathy, and it's my colleagues. We have a special center for amyloidosis, and I'm not in it, but I'm adjacent to it. So I hear a lot of comments, but I don't have the specific data. But I know that my colleagues do lots of fat biopsies when the disease is suspected. But I don't really know the turnout. For ATTR, yes. And they do also check the fibril length, etc., in the biopsy. But I'm sorry, I don't have the specific data of the turnout. But it's used a lot. And about the specific treatment, just a comment, you said you named diflunisal, which is an old NSAID. We are not allowed to use that in Sweden simply because there are specific treatments now accepted by our government. So then we are not allowed to use older treatments. So that creates a dilemma. We can't choose a cheaper treatment for, say, an older patient, and that might mean that they're not treated at all because these new treatments are more expensive.
Okay.
This is a very important comment. I mean, on the other hand, probably we need a real controlled data, because to administer a very expensive drug without knowing, just according to our medical advice is not, I don't think is correct, both for doctors and for patients. So I think it's considering that these are elderly people, and maybe there will be other kind of diseases and causes of mortality. I think if there are no symptoms and no cardiac involvement in terms of of imaging, of cardiac imaging, it is wise just to watch and wait. Have let's say some tests every year, and see if something happens. Then it may be allowed. We may be allowed to start treatment. Otherwise, just watchful waiting, I would say. What do you think, Elisabetta, about that?
Yes, yes, I agree. I completely agree.
I think we do not know many things yet about the disease and the expression of the disease in various organs. So there may be additional factors that so far we do not understand that make, let's say, the tissue-specific involvement in a systemic disease. And until we have clarified this, I think it's reasonable to treat only patients with initial symptoms, or at least with some non-invasive evidence of involvement of the, let's say, vital organ such as the heart. But I mean, we do not have answers. We need more data, basically.
Yeah, and we can also use some parameters of the left ventricular function, maybe. Just if we see deterioration of the left ventricular function or the left of the strain, maybe could add.
That's exactly what I was alluding to. And we have very sophisticated now methods, even a strain, to see whether something is progressing in the heart, in the function of the heart, and then we can probably target some patients for an early treatment. But yeah, lots of work to be done still. So any other questions? Any other comments? If not, I think Elisabetta should, let's say, be congratulated for this very interesting webinar. So we can, I think, conclude because we are also on time. So thank you very much to everyone. And you know that the meeting has been recorded, so you can also, I mean, listen to it later on when you are not busy, you're not on duty, and it's another possibility to refresh your memories on this very interesting topic.